The training's been a lot. It's very intensive, and I've studied, I've taken tests, I've studied, I've taken bigger tests, I've studied, I've taken even bigger tests, but I've learned. And it's an important enough topic that it's worth all this effort to learn how to do it correctly, because that's the key of making the decision to become a prescribing psychologist, is to want to be really good at it and do a good job for my patients. And so while I am a little tired at this point, because the overriding factor is that this is the coolest thing to do. I'm so happy that I made the decision to become a prescribing psychologist. It's a new way to help my patients, and it's a incredibly needed way to help my patients. And for me, that's everything about my work life, right? I want to do well by the people that I work with, and I've seen there's been such a gap in the way I've been able to help people, and having to work out ways for them to have that gap filled is harder on my patients, and of course, challenging for me. So to be able to fill that gap myself, I think is going to be a critical part of the work that I do with folks. When I was trying to decide if I wanted to be a prescribing psychologist or not, one of the things that happened that sort of tipped the teeter-totter was that a patient that I had helped get clean and sober years before called me in tears, "Claudia, can I come back and see you again?" And I'm like, "Sure." I got her in that week, a day or so later. And when she came in, she was obviously showing, even for me before I learned my practice of being a prescribing psychologist, obviously showing symptoms of EPS. And she could not get a hold of her psychiatrist. She tried, I tried, because sometimes Dr. Mosier can get through, and I couldn't get through. And it was an easy fix. All she needed was an anticholinergic medication, but I couldn't give it to her. So I had to arrange for her family to come and take her to the emergency room. It had been so long that the symptoms had been going on that she needed to be hospitalized. She was a woman who'd had an extreme amount of trauma in her life, and being hospitalized set her back quite a bit. She didn't relapse, so I was very proud of her for that, but her trauma symptoms exacerbated. And all of that could have been avoided if I could have helped her. And I realized that I needed to get the training to learn how to do this for folks. I hear in other people that I've been working with here about how important it's been to have me there helping making the decisions about the medications, because I work primarily with LGBTQ folks, lesbian, gay, bisexual, transgender, queer, questioning, gender expansive, anybody who fits under the rainbow flag. And it's scary for them to make a relationship with a practitioner because they don't know how they're being viewed. And a lot of times practitioners, prescribing practitioners, only get a few minutes with a person. And if they're not part of the community, if they haven't been LGBTQ competently trained, they're making those decisions through the lens of what they've just learned in society, and perhaps through the lens of prejudice. I had one psychiatrist tell me once, all lesbians are borderline personality disorder, and all gay men are histrionic personality disorder. And my question from that, if you are prescribing through that lens, how are you going to get the medicines right for that person when you don't have time to really get to know that person? For me, I've spent my whole life working with LGBTQ folks, and I have the time as a psychologist to spend more time with a person than many prescribers do, where they're in such hurried situations that they're only able to spend a few minutes and they have to make these major decisions. I can work with a person for a while. I can help them through the process of deciding if they also agree with wanting to take psychotropic medications. I can talk with them about their fears, their concerns. I can talk with them about their hopes. And I can use my training to make decisions about, what are the symptoms, what class of medication is going to work best with these symptoms, which of the medicines in those class, how much to prescribe. What about their other physical illnesses that they have? A lot of my people are HIV positive. Some of them are getting older and they have other physical illnesses. Of course, with the chemical dependency, I work with a lot of people that are in early recovery from chemical dependency. It's a big responsibility to make those decisions, and it took me a while to be willing to do it, because it's like, here, put this in your body. That's essentially what I'm saying, and that's a scary thing to say to somebody, but I didn't know how I would get to the point of being able to do that. But when the moment theoretically came, of course, I'm not the one writing the script yet, but in my training, when that moment came, it was really interesting. I saw the pain, and I saw something that would help the pain, and I was willing to take the responsibility to prescribe the medicine. You study a lot, you read a lot. Every step along the way, I began to think I understood it, and then they'd teach me something new, and the paradigm would explode, and I'd have to think about it in an entirely different way. It was like that through the entire training. There was a patient who was known as schizophrenic, and they came into the hospital, and they were having the experience of having bugs under their skin, and the only way that they thought they could get rid of them was to set themselves on fire. And so the first prescriber that saw them got them started on an antipsychotic that had worked before. That wasn't working quite well enough. They put them on a second one from a different class. That wasn't working. Then we got him, or got her actually, and asked a few more questions. That's the thing about being a psychologist. We're taught, ask the questions that your parents told you never to ask anybody. And that's so ingrained in my training as a psychologist. We asked the questions and found out that she was actually withdrawing from benzodiazepines. So the whole bug thing mixed in with the psychosis, because that's one of the symptoms of withdrawal from benzodiazepines, which is a dangerous withdrawal. So we were able to then fix that, help with the withdrawal, back off on the antipsychotic so that it was, her original dose was actually correct. It's just with the benzo use, she had stopped taking it, and then had the trouble with the benzodiazepines. And if I just looked at it from the, because I got to tell you, my first thought was, oh, this is psychosis. I've seen this psychosis where people feel they've got bugs on them before. But fortunately, the training kicked in, and it's like, hey, you got to look at this and look for another answer because the first one's not working. And helped with the benzodiazepine withdrawal, so it was a safer withdrawal, because you can have seizures, you can die. You have psychosis from benzodiazepine withdrawal. So is this psychosis from the withdrawal? Is it from the schizophrenia? So you got to get the withdrawal out of the way. Because of all that work in those classes, all those classes and all those tests, they work. It's hard, but it gives you the training that you need to be able to make these critical decisions. I think this is a piece that's been missing from the healthcare system. To have work siloed the way it's been siloed. This one works on the medicine, this one works on the talk therapy. Having a person who bridges between those silos, I think, is incredibly important. I keep often coming back to time. I feel bad, I think, for many prescribers, because they have so many patients, they only have so much time, and they don't get to do the therapy work. They don't get to sit with the patient and really get to know the patient. As a psychologist, I can do that. So I can mix my practice. I can do some just therapy. I can do some therapy with medications. I can do some medication only. I see my practice as probably being mixed like that. One of the things I really want to do in my practice, because of having seen people have so much trouble getting their medicines, is to always, and the prescriber that taught me also does this, is to every week have a certain day that there's a few hours that are open as open clinic, so that if somebody misses an appointment, needs to get in, and can, just as medication, not so much for therapy for this, but needs to get in and have the medications adjusted. I think that's a critical thing that I can do with my practice that I do want to do. I like working in the hospital. I like the acuteness of it. I like the figuring out, this person is in distress, what can we do to help this person get back to baseline and then be able to thrive from there. I like working within a system where I work with social workers. I like working where I can talk with other psychologists. I like talking with the physicians. Now that I'm learned how to prescribe it, I talk with other doctors now about how they're doing the prescribing. I had a patient come in recently that was so depressed, and she was on a low dose of an SSRI. she was willing to take more of the SSRI. I called her physician. She was being prescribed by an internist. She's a transgender woman, so she really has had horrible times with the medical profession, so she wouldn't go see another doctor. She would only see this doctor or me. So I called the doctor. The doctor said, well, let's put her on another antidepressant. I was like, wait, what would you please consider raising the dose of this one first before you bring in another subset? She doesn't have reaction to this medicine, a negative reaction to this medicine. Why bring in another whole subset of side effects? Let's maximize this dose first. And so the provider was willing to do that. Of course, the provider told her, oh, you only need to take the higher dose if you're feeling depressed. Which isn't...
This is an internist.
Yes,
yeah.
This is an internist, yeah. Which isn't how SSRIs work
right.
best.
Right.
And so now I'm having to work with her about, let's try it this way if you wouldn't mind. Yes, I am so happy that I took the plunge and decided to do it. It was, it was a big deal. I'm not the youngest person in the world, but I decided that I was going to be that older age, whether or not I took the training or not. You certainly can teach an old dog new tricks. I've blown that stereotype out of the water, and I just love being able to talk to my patients more openly about their psychotropic medications. Before, when I was just working with my psychologist license without the master's in clinical psychopharmacology, I was limited by the ethics of practicing outside of my range of expertise. Now I've got that master's in clinical psychopharmacology. Now I can talk to them more directly about their medications. I can talk to their prescribers more directly about the medications, and I am finding my patients are adhering to their medicines. Adherence is a big deal, right? About only 45% of people take the medicines as directed. And my patients are adhering better. They're asking more informed questions of their prescribers. I'm having better relationships with their prescribers. And my patients are getting better care already, even though I'm not prescribing yet. If you're thinking about it and you're scared about it, do it anyway. There's such satisfaction in helping patients in a different way from how I've been able to help them as a clinical psychologist. And that satisfaction has widened. Being a psychologist is like a journeyman's card, right? It gets you so that you can do so many more things. And this is one of the more things that we can do as psychologists that nobody else in this world can do. Where there was a nurse practitioner prescribing, and she really wanted to help, but she didn't have the psychology background, so she didn't know how to talk with the staff about, okay, these problems are happening in this residential program only at night. What's different at night? Is the staff different? Are they loading them up with sugar? Is there something going on? And she didn't have the psychology background. She only had the prescription pad, and she really wanted to help. So the doses, of course, were going up and up and up. Being able to blend all this together can give a healthier version of treatment for people.